Did you say which chapters were supposed to be on exam 3?
I can't hear you.
Did you say which chapters were supposed to be on exam 3?
Not yet. I have not said what chapters are supposed to be on exam 3 because I have not prepared it yet.
Okay.
All right, so once I prepare it, what I've done is I just uploaded everything from last year into the Canvas site to kind of have on the grade book exam 1, 2, 3, 4, 5, and 6, and then I start from scratch, but I've got the placeholder, so to speak, with that. So
exam next Tuesday, you'll let us know what's on it.
Yep, and I will let you know as soon as I know. How's that? It's going to be module heavy, I think, too, because we've got a lot of modules that I need to get you caught up on.
This is for exam on next week, right, Ms. B?
Yes, yeah.
Okay.
Yeah. So we are moving ahead, say, with Garrett, with the instruments. And if you haven't had the instrument yet, I'm not going to test you on it until you actually have it in your hand. So that's the kind of thing I have to kind of customize. But I know EOIO is going to be on there, and some of these earlier chapters on infection control are going to be on there. For example, possibly this one, which is chapter 5. And the nice thing is with this, you've had some of this stuff already in radiology. Not to the depth that you're going to be getting it in pathology, and not to the depth we might be doing it in here, but you know what standard precautions are. You have an understanding of that as we go through and discuss it. So let's get going, okay? Standard precautions, okay, we're going to be talking about first. This is our chapter outline, which just takes all the headings and goes through them. Our learning objectives, this is what you can use to know what you're going to be tested on. You have to know what standard precautions are and the difference between standard precaution and universal precautions. You need to know the infectious disease process and all the components of it. Transmissible disease, what is considered there as far as aerosols, droplets, spatter, splatter, and as well as the oral health needs of those infected. And now, since we are dealing with COVID, it is really bringing it all down to the reality of this isn't some abstract information. It's things that you're dealing with on a day-to-day basis. But let's talk about standard precautions. Okay, so you need to know that standard precaution does protect all dental health care providers, DHCPs, as well as the patients. And that represents a standard of care that presents us as well as them from pathogens that can be spread by blood or any other body fluid, excretion, or secretion. So it applies to all patients. We can't do one thing for one patient because, oh, they look like they might be sicker than another patient. Oh, they look like they don't have anything, so I don't need to do this for them. We have to treat everybody equally. So it applies to all patients. And it applies to the contact of the different fluids that we're going to be in contact with. The first one is going to be blood. All body fluids, secretions, and excretions, except for sweat, regardless of whether they're found in the blood, can have bacteria in it. So we want to be looking at non-intact skin, intact skin, and then additional transmissions. How are they going to be transmitted? Well, one of them is through droplet formation, and respiratory or mucous membranes contact transmission through airborne droplets. Sneezing, coughing, guess what? This is what COVID's all about. This is what the SARS virus in the early 2000s was all about, these pandemics. It's droplet formation. So we've got our Mycobacterium tuberculosis, our influenza virus, and chickenpox virus, all through droplet. Then there's also contact precautions, and you want to reduce the risk of transmission of organisms and specific diseases by direct skin or indirect contact. So that could be other things like your E. coli, your MRSA. And then there's airborne precautions, and you want to be able to reduce the risk of airborne transmission of infectious disease by the droplet nuclei. And then, of course, we have our sharps. That is, we want intact mucous membranes. We want intact skin. So if we've got a break in our skin, that is an opened area where all of this droplet and everything else can take hold and take residence. I don't know if anybody else watches The Monsters Inside Me. It's one of those cable shows. It's amazing. I'm never eating sushi because you never know what's living in that raw fish you're eating. And then it burrows its way up to your brain and nobody can diagnose it. Anyway, so intact mucous membrane. Okay, we've got hopefully in the oral cavity intact mucous membranes, but not always, because we always have some sort of infection that we are seeing with patients. So we're looking at the pathogenic or the disease producing bacteria and viruses. The potentially pathogenic and non-pathogenic microorganisms may all be present in the same mouth. So I'm talking ahead of me here. So we are dealing with our mouth. This is where our mouth and our lungs, where most of the microorganisms originate, and that's where they aerosolize and get into the air. So everybody, all of us have an infection potential within us as a human being. What we want to avoid is that cross-contamination, and that cross-contamination is person to person, person to inanimate object. So that is everything that you're touching. And then the inanimate object, what you touch, it then goes to another person. And this is something that I was really made aware of back in the early 80s when we started wearing gloves because of HIV. And I was noticing, especially the doctors were putting gloves on, and then they were forgetting to take care of what are they touching, because they were protected with the gloves, but they were just touching everything under the sun. And as a dental assistant, you poor dental assistants, we're having to run around and try and chase after everything that the doctor touched. So it's person to person, person to inanimate object, and inanimate object to another person. So when you're saying, why am I wiping down these cabinets and the drawer handles and everything, that's why. Okay, we want everything as sanitized as possible. So we've all got the potential of being pathogenic, but inadvertent transmission to other patients is what we need to avoid, as well as ourselves. So part of this could be inappropriate work practices, in careless hand washing, unhygienic personal habits. Now, one of that is, we're using our gloves and our face masks and everything, but are you touching them after you put your gloves on? It's amazing the habits that we have that we don't realize we're doing, myself included, until somebody points it out to us. So, so that's part of our job, and part of your job too, is to allow us to know what we are doing with ourselves. You just touched that, you just touched this, you picked your nose and then you tried to go into that person's mouth. Not acceptable. unhygienic personal habits, as well as inadequate sterilization and handling of the sterile instruments and materials. So Mariella, who's our lab manager, is in charge of taking care of the sterilization. You're in charge of cleaning your instruments and getting them packed. Then she will sterilize them, and she's in charge of testing the sterilizers and the autoclaves and everything to make sure that they are in good working order. And she keeps a log of that. But once they come out of the autoclave, then you're in charge of them. They go into the big cabinet, and as you know, the outside of that packet is not considered sterile. So you want to be careful where you're placing that. You've got your bare hands when you're using them. You've got it underneath your arms as you're carrying a bunch of stuff. So that's not considered a sterile field anymore. So after touching the outside of that packet, you need to be aware of where you're placing it, as well as if you're in gloves and you're opening everything, you want to change your gloves before you put them back on. So inappropriate work practices, we will be teaching best practice. Sometimes it's not possible to follow through on all things all times, but we do the best we can in the circumstances that we are given. So, essential features of disease transmission. Now the book goes into a lot of other things, what an aerosol is, which is the smallest particle. Then there is spatter, which is a little heavier. And then there's splatter, which is even bigger. You want to know what the origin of that spatter is. It's really fun being a dental hygienist and you're scaling or polishing and you're feeling something boop, hit you in the head, the forehead, and you're going, eh. So no matter how protected we are still exposed to everything that's in the air, and we're taking it home with us. So again, we want to minimize the effect of what's going on. So what are some of the infectious disease processes here? One of them is dust-borne organisms, and that's my problem I have in my house. I dust, and then guess what? The dust comes back. So, but you have to keep up with it, because in the dust are the pathogens as well, and some pathogens live better and longer in dry areas than others. And then we've got the aerosol and the spatter, which are wet. Aerosol is very fine and it can stay suspended for a number of minutes. It used to be with the COVID that we were supposed to wait 15 minutes after the patient left before we even started to disinfect the operatory because of the aerosols that were still filtering down. The CDC has waived that, so we don't have to wait 15 minutes. But when this first started and dentistry was going back into operation for emergencies, they were telling us that we should have 2 operatories and leave one while the other patient's being treated, and then go in and disinfect, because that would be a half hour, 45 minutes to allow for everything to fall. So we have to be aware of what's going on. No longer are we setting up the night before. So in the morning, all we're doing is flipping a switch and we're ready to go. We're not doing that anymore. Everything has to be put away in the morning. Everything has to be sanitized again and then taken out. That's fresh. So we want to be working in best practice. With COVID, we're getting into airflow, air filters, how the air is going, all this other stuff. So we are only getting better and better as we move along. So the infectious disease process, we want to prevent transmission. Airborne infection can be controlled. We're using HEPA filters. We're now looking at how many filters we have in the office. We're looking at the airflow. Where's that intake airflow, and where's the patient's head compared to that inflow? So offices have been taking a look at this. We have been using a pre-procedural oral rinse for years. Even when I was a student back in the late 70s, early 80s, we were doing pre-procedural mouth rinses. Now the discussion is, well, what are you using for a mouth rinse? Is Listerine going to be effective? Is Scope going to be effective? Do you need chlorhexidine? Do you have to have the hydrogen peroxide, the bubbling base for the COVID? What is the best for the times that we're doing? We do not have the oxygenating mouth rinses in school, so we're using the Listerine. A couple of the courses I've taken on the COVID, because of the COVID, it does not survive in the peroxide base solutions, but think about where the virus is. It's in your lungs. You do a pre-procedural mouth rinse, you swish and spit. Well, if you are breathing from your lungs, where's the air coming from? That pre-procedural rinse isn't getting to where the nidus of that infection is. So part of the discussion is, yeah, it's great to use your peroxide rinse for the COVID pre-rinse. However, how effective is it really? So you do what you can, and with that, you're doing a pre-procedural rinse, but you're also minimizing the amount of aerosols that you're producing. So we want to interrupt the transmission in anywhere of that chain of infection, and that can be almost anywhere. We want clean water. Our water lines, just for your own information, have filters in them that are replaced every year. They're in underneath the units, and they're not straws, but they're a cartridge, and it's supposed to be good for 365 days, and they get changed every year. So that is supposed to keep our water lines at a safe level. Our safe level is, it's called, oh, I just lost my train of thought. You measure it, all right? And we're going to be getting some test kits in where it's 500 colony forming units, CFUs. That is what the government's stating our drinking water needs to be. It needs to be below 500 CFUs per milliliter, and our water lines in our dental units are supposed to mimic that same bacterial count. How do we know? We don't know unless the water is tested. But what we do know with the water lines is that they collect a lot of biofilm in them, because the smaller the hose or the lumen, the greater the biofilm accumulation is going to be. So that's why when you come into clinic, you are flushing your water lines for 2 full minutes at the beginning of the day. You're flushing the eye wash stations to get new water, to get the old stagnant water out and the new water in. So the last thing you want to do if you've got something in your eye that you need to wash with an eye wash station is water that's been sitting there for a year. All right, just think about it. Yuck. So you're flushing the water lines even in between patients for 20 to 30 seconds in private practice. You're making sure that you've got a constant flow of that water. We want to protect the clinician. That's you. That's all of your PPE. With the aerosols, we've got the hair bonnets now. We've got disposable gowns that are going over your fluid-resistant jackets. We've got shoe covers, which we're not wearing because they are slippery as all get out. But when you start using aerosols with yourselves and with your patients, you're going to be dressing a little bit differently, okay, to, again, protect yourself so you're not wearing these things home. We don't want your backpacks and all this other stuff in the clinic with you, right in the line of fire where all those aerosols are. So when we start producing aerosols and you have to bring a lot of stuff in, we're going to be asking you to possibly store things either in the dental skills lab or in one of the radiology rooms, just to keep it away from all of those aerosols. That's protecting you, the clinician. We want to protect the patient as much as possible too. We don't want that bacteremia going in. We don't want them swallowing the bad water. We don't want them inhaling bad air. So we want to protect the patient. We don't want anything from that last patient to be entering them. So we have to maintain infection control protocols, and your office should have, when you're working, should have an infection control person, somebody who's in charge of the bloodborne pathogens and the OSHA updates. We are required, employers are required to have an OSHA update every 365 days. Once a year, they have to have training for all of their employees. A new employee, they have 30 days to get them up and running with their OSHA protocols and bloodborne pathogens. So this has to be logged. I'm the continuing education chair for the Northern Virginia component of my Hygiene Association, and every October we have an OSHA and bloodborne pathogens update. I will be inviting you to this. This will be my first attempt at virtual, and you know how good I am at technology. But we have a wonderful dentist who teaches at the University of Maryland, and he is an infection control manager. He's the one that manages all of that. That does a great presentation. It's going to be in October on a Thursday night, 7 to 9. 22nd, I think, or something like that. So I'll be giving you information on that. And you can be inviting, if you're working, you can be inviting your offices as well. So it's important for us to maintain infection control protocols, and the more meticulous you are, the better you are. I'm one of these people that have been cursed with seeing the details and things. I don't always see the big picture, but I get lost in the rabbit holes. You know, I'm the one that's walking by and I can tell, oh, you got the wrong socks on, whatever. It's just, it's some of us are like that and some of us aren't. So we need to monitor each other, because those of us that aren't meticulous, it's not that we don't care, it's just that we don't have the thought process ingrained in us. Think about wanting to adjust your safety glasses with your gloves on. You adjust your safety glasses, you got to change your gloves. We don't even realize that we're doing this. So this is the chain of disease transmission. You've seen this before with Mrs. Heberly, and you're going to be seeing this again throughout your time at Northern Virginia Community College, and you will be seeing it again, yet again, on your board exams that you take. But if you notice here, this is the chain, but you can break that chain anywhere. All right, clinical identification of lesions here is for the infectious agent using standard precautions will break the chain. Health of dental teen immunizations, all right, can break the chain of the reservoirs. Standard precautions, standard precautions, standard precautions, standard precautions, standard precautions. Standard precaution is one of the best things you can do to break the chain of infection. So what test questions are going to be asking you is talking about the chain of disease transmission, what part of it deals with body fluids, for example, and I'm just pulling that out of my hat. And right here, body fluids is the port of exit, okay, or skin and mucous membrane. Droplet spatter is the port of exit. Versus port of entry. If it exits someplace, it's got to enter someplace else. Body fluids, skin and mucous membranes, droplets and spatter. needle stick, and inhalation has been added to the port of entry. So review that. It's common sense once you have time to digest it. Now we've got to get into some of the nitty-gritty here. And let's talk about some of the pathogens that are transmissible from the oral cavity. Oral cavity, so we're talking about the whole mouth here. Selected pathogens can be transmitted from the oral cavity, and their disease manifestations, their mode of transfer, their incubation period, as well as how virulent they are all on a table in the textbook someplace. So it's got everything in one spot for you. But pathogens are often present in the oral cavity without producing any signs or symptoms of the patient. So we don't know what they are carrying or harboring. So we're talking about tuberculosis, viral hepatitis, herpetic infections, acquired immunodeficiency disease, the HIV/AIDS are all included in this chapter that you're going to be reading because of the special problems they create in both personal as well as patient care. And if we are treating one patient a certain way with our standard precautions, we're treating all patients in that same way. So we're treating essentially everybody as if they are infectious because we don't know who is or who isn't. So we're treating them all with the same standards of care. So let's talk a little bit about tuberculosis. This is, it's on the rise again. We thought we had it licked, but we don't. It's an inhalation bacterium. So TB is contracted when a vulnerable person inhales aerosolized droplet nuclei containing the TB bacterium from the sputum or saliva of an infected individual during coughing, sneezing, speaking, singing, anything that, you know, if you're a spitter when you say your P's, you know. So the use of ultrasonic scalers, air polishing, and other hand pieces, and the air water spray creates the aerosols that can actually carry the TB, the tuberculobacilli. So the droplet nuclei are small enough to pass through over 95% of the bacterial filtration efficiency required of standard surgical masks, and they can remain suspended in the air for hours. So standard precautions may be sufficient to protect the dental health care provider, which is you, from transmission, but not necessarily the next person who's in the chair with their mouth open. So airborne infection isolation measures are necessary if you know that you have a TB infected patient. Now, with us in general practice and in perio, we don't treat active TB. It's an emergency only situation. So if we have somebody who has a productive cough and a fever, we're not diagnosing them with TB, but guess what? We're not going to be seeing them. And that's the importance of having the medical history before you even start. We're taking temperatures on ourselves, we're taking temperatures on our patients, and we're asking the COVID questions. So that's the first thing before the patient even comes back. We've got their temperature, we've got their history for the last couple of weeks. If they are suspicious with COVID, we're not bringing them back. But maximum communicability is usually just before the disease is diagnosed. This is with most things. When the person doesn't even have any knowledge that they are really sick. Oh, I just have the flu. I've got this nasty cough that won't go away. I must have bronchitis that might be turning into pneumonia. That is really TB. Who knows? Who knows? But with TB, the infection is primarily the lungs. It can affect the lymph nodes, and that's something that you're feeling with your EO IO, the meninges, the kidneys, the bone, the skin, as well as the oral cavity. And there's another chapter that we'll show you later on next year about what TB looks like inside the mouth. But for clinical management, the Center for Disease Control tells us that we're not going to be treating patients. We as healthcare workers need to be screened annually for TB. And that was one of those things that you needed to upload on Castle Branch before you came in. So they've got 2 different types of tests now, the skin test, and now they've got a blood test. And we have people that are coming from other areas of the world that were treated with something when they were a kid. So they're always going to be tested positive with the skin test. So then they need a lung x-ray just to verify that everything's negative. But there's all of the protocols that are put in place to protect you as well as those that you're in contact with. So we need really a thorough medical history. We need to be able to refer patients with symptoms. Okay, we don't make the referral. We talk to our employer about that and they make the referral. We just are kind of the case manager, giving them all the data that they need so they can make an informed decision. Urgent care are generally sent to the hospital if they are having active TB. We do not have the means for an isolation room and negative air room, all of that other stuff that is required in order to treat somebody with TB. Respiratory protection is a minimum of an N95 filtration mask, as well as other barriers. We have N95s that our second-year students are using. They're treating their patients, and then they're putting a level 1 mask over it. And you don't take that N95 off for the duration of the morning. But we want to separate any suspected patient from our general population. So you've seen over the time, you've seen a lot of these kind of slides, right? And this cough, this sneeze can go 8 feet forward and 8 feet up. It is really light aerosol, so it can stay suspended for a long time. So we are wearing face masks all the time, all the time. Let's talk now about hepatitis. The viruses with blood-borne route of transmission are contact by infected body fluids. That includes the hepatitis B, hepatitis C, we've got hepatitis D virus, and their HBV for hepatitis B virus, HCV, hepatitis C virus, and HDV, hepatitis D virus. And they, there are a number of hepatitis viruses out there. So let's start talking about the most common one right now, and that's your Hep V, HBV, right? Viruses with blood-borne route, okay, contact with infected body fluids. So this is definitely a blood-borne transmission. The modes of transmission is through percutaneous or perimucosal exposure. Percutaneous includes, okay, the intravenous, intramuscular, and subcutaneous. Accidents with needle sticks and other sharp instruments are percutaneous. Exchange of contaminated needles and syringes. So those are more with the drug paraphernalia. And perinatal transmission. Maternal transmission of the hepatitis B virus to the fetus is efficient, and it's not as rare as we think it is because the blood is being shared, and this can lead to chronic liver disease and cancer as well if the hepatitis B is not treated. So we are getting tested for hepatitis B. They now have vaccines for hepatitis B. And if you choose to opt out of the vaccination, then you need to have a refusal form on record with the school, with your employer. Then we have hepatitis C. Hepatitis C used to be a death sentence, but antibodies were discovered in 1991, and then blood screening became on the market in 1992. But hepatitis C is primarily transmitted parenterally and other modes similar to the hepatitis B. Transmission rarely occurs from mucous membrane exposures. Environmental contamination with blood containing hepatitis C really isn't a significant risk factor, but sexual partners with hepatitis C is a significant risk factor. So for prevention, you want to educate and behavior modification, strict attention to the standard precautions, and now they have antiviral protocols for hepatitis C that can actually eradicate the virus from your system. So it's curable now. Used to be if you had hepatitis C, we knew eventually you were going to need a liver transplant. Then there's hepatitis D. That's called the Delta hepatitis virus or Delta agent. And you can't get hepatitis D without already having hepatitis B. And that's the big thing you need to take away from hepatitis D. You already have to have B because it's superimposed with the hepatitis B antigen. And that really is about the depth that I need you to go into for that. We've got HPV, human papillomavirus. Herpes virus diseases, okay? This has been in all of our journals. It's been in a lot of the communications for the last number of years because HPV can also lead to certain cancers. It's even on commercials now on television. So we need to be comfortable discussing these things with our patients. And it's not an easy topic to address, talking about sexual habits with even teenagers and drug use. We have to try and be as non-judgmental as possible, but we want to protect our patient. Here's your form. The table that has all of the herpes viruses on them. Look at all of them. They go up to number 8 on this one. Primary herpetic gingivostomatosis. Okay, that is the overall initial outbreak that the patient gets. They've got sores all over their mouth. Then that tends to resolve and the virus stays in your ganglia and it's very opportunistic. So it just lays there dormant and then it waits for an opportunity. The first time you're you get sunburned, for example, is a lot of times people will get that herpetic lesion on their lip, okay, because they go out to the sun for the first time. Stress can do that. But herpes labialis, that's the herpes simplex ulcer that you get on your lip, labialis. Herpetic whitlow is on your finger. And there's ocular or ophthalmic herpes as well. I can't even imagine that one. Now, I was a new graduate in 1981, and I was taking a course on malpractice and risk management. And this was before HIV had been discovered, the cause of all of that. So this attorney, who was also a dentist, was telling us a story of a hygienist who managed to transmit the herpes virus to 123 patients. They had been seeing this hygienist, and about a week to 2 weeks later, all these patients were calling in saying they had their mouth full of sores and they couldn't determine why. So they called in an epidemiologist, and they were able to find that the hygienist had cleaned somebody's teeth, and she had documented a herpetic lesion on the lower lip. We weren't wearing gloves at the time. She contracted the virus on her fulcrum finger and managed to transmit that virus to everybody who already wasn't infected with the hepatitis B virus. 123 patients. We started wearing gloves that next day. I went out and bought my own gloves because my employer wouldn't supply them for me. But at the time, the science was also saying and they were latex, we could wear the same pair of gloves for up to 5 patients and still enter the patient's mouth with a cleaner hand than if we were using our bare hands with our nails and our cuticles and everything else. And we're going, ugh. So we tried re-wearing the gloves from patient to patient, but we were using alcohol to disinfect, and we were using, soap to wash our hands with. So luckily, the gloves got tacky and sticky, and we couldn't use them for more than one patient. But we tried, because the science said up to 5 patients, and we're still doing a good job. We can't even think about that today, can we? How many gloves would you go through in an appointment? Herpes simplex virus 2, that was herpes simplex virus 1. Herpes simplex virus 2 is more of the sexually transmitted genital herpes, neonatal herpes, and there is antiviral therapy for these. There's antiviral therapy for herpes simplex 1 as well. The standard is, how many cold sores do you get in a year? If you get more than 5, then you might be a candidate for antiviral therapy. If not, then you'll just treat them as these symptoms come up. And usually there is something called a prodromal effect, where there's a little bit of tingling that occurs before you get the outbreak. And if you can get the acyclovir or one of those medications, antiviral medications, in soon enough, you can stop it from turning into that blistered form. So review the different types of viruses here. Herpes zoster, okay, are the shingles. You've got your varicella, which is your chickenpox. They now have a vaccine for chickenpox. So you all, the younger ones, have never had chickenpox. You've had your vaccine. When we had chickenpox and measles, there were 5 of us. I had 4 brothers. When the oldest one or somebody came in that had them, we all had to go play with our brother. And so that way, all 5 of us were sick at the same time, because my mother was not about to do that 5 separate times. So anyway, that's the old way to do it. But with the chickenpox vaccine, we have almost eradicated that, so we should also not be seeing the shingles. Now shingles, because of the virus stays in your ganglia dormant, and eventually it likes coming out. The shingles is usually on somebody who's older, and it occurs on half the body, and you can see a straight demarcation line if they've got it on their face, for example, or their chest. It's like somebody drew a line down the center of their body, and the blisters are on just one side, and it doesn't go beyond the other side. They do have immunizations for both chickenpox and shingles. Then you've got your Epstein-Barr virus. That's your number 4. You have mononucleosis, And then you've got also hairy leukoplakia. All of these, the last two, can be symptoms of the Epstein-Barr virus. The cytomegalovirus is a widespread virus, and the most severe disease develops in infants infected in utero and in immunocompromised patients with the HIV/AIDS. The transmission is respiratory, especially among children, and sexual transmission, as well as going from the mother to the baby. It can be transmitted through the birth canal and through breast milk. We've got number 6, herpes lymphotropic virus. It's widespread distribution among humans. The prevalence is close to 90% by age 5 in the United States. So this is one of those childhood diseases or viruses that we get. Reactivation can occur after bone marrow transplant. So if you're immunocompromised, you have to be careful because it's always there. Number 7 is related to number 6. There is a periodontal connection with this. The gingival tissue may serve as a reservoir for this. High prevalence of number 7 was detected in both periodontally diseased and in healthy gingiva. So this is something that a mouth could be carrying. And we've got number 8, which is the Kaposi sarcoma, which is related to HIV. I don't expect you to know each of these numbers and what they are. Just know that there are 8 of them and just get the general characteristics. You'll be going into this in much more depth when you get into pathology. Then the HPV. How many of you had, and I don't expect you to answer this, but how many of you have had immunizations for HPV already? There are over 100 types of HPV, okay? So 150 now they're saying. There are 40 types of HPV that can infect the genital areas of both men and women. It can also infect the mouth and the throat. So types 16 and 18 are the ones that we are really concerned at, but 13 types can cause cancer. Type 16 like to progress to 95% of the head and neck cancers, and 63% of the oropharyngeal cancers are associated with type 16. So it's something, this is something that we spend time talking to with our teen patients and preteen patients, because they think if they're not actively having intercourse, that they're still being safe, and they're not. HIV/AIDS infection. Just read over that. It was first recognized in 1981. That's the year I graduated from dental hygiene school, as clusters of diseases that were characterized by a loss of cellular immunity. It took us a long time to figure out what was killing all of these people. And now we know, but the nice thing about now when you are diagnosed is it's not a death sentence. They have antiviral cocktails that patients are on that can limit the viral load. You will be seeing HIV patients in your course of your time here at NOVA. And it's, with the proper precautions, we are not at risk, nor is our patient at risk for getting any sicker. And that's the first thing we want to do, is make sure that the patient's not going to be getting any sicker. So we are going to be asking for their latest blood work to see what their CDT numbers are and those type of things. So take a look at the HIV and AIDS. you'll be getting into more of this again with your pathology. So I'm not delving into it here in your dental hygiene. Oral manifestations, though, you're doing your EO-IO, and this is something that you just need to be more aware of. Oral lesions that are strongly associated with HIV and less associated with HIV. And what is the impact of this antiviral medication that they're on? The HAART is the antiviral cocktail that they're on. And there can be some oral manifestations. Patients can have pre-exposure prophylaxis and post-exposure prophylaxis. These are some of the medications that are commonly used with HIV. I'm not going to be asking you to know this. You will be having pharmacology, you will be having pathology. But this is why you need your drug cards available. If you don't have your drug cards, then you're going to be using the LexiComp. So your drug cards are something that we'll talk about later on, but you can actually purchase a box of drug cards so you don't have to look up everything, and that will save you some time. So that way, if you have a patient that is on a particular medication, you've already got the drug card. We've seen so many times patients spending the entire 3 hours of working with their patient, just going through the medications that they're taking and trying to get the drug cards. So the more you can do ahead of time before your patient sits in the chair, the better. For your dental hygiene management, we need to know that we are obligated to treat everybody ethically and treat everybody the same. If you've got AIDS or HIV, I can't say that I don't want to treat you. Okay, that's illegal. That's illegal. So we have to treat everybody the same. We have to allow them the provisions to maintain oral hygiene, and we need to know what we're looking at and what some of the side effects are for these medications. And that's something that your drug cards will be able to do when you research that, because there could be other medications that would have less of an effect than what they're on. Same thing with calcium channel blockers with for blood pressure and that type of thing.
Ms. D?
Yeah.
How about if the dental hygienist has HIV or the hepatitis? Is there any special protocol that we're supposed to follow?
No, universal precautions is supposed to take care of all of that.
Okay, thank you.
Yeah. So MRSA, let's take a look at this MRSA. Oh my gosh, is that ever prevalent too? Okay, so that is a specific resistant type of virus. It's resistant to antibiotics. This is something MRSA you see go through nursing homes. You see it go through the hospital. They're usually some sort of hospitalized or institutionalized patient that has MRSA. Very difficult to treat. So again, everything ends with documentation, my friends. We want to list their medications. We want to know what consultations they've had. Do they need to be referred? And do we need copies of their test results? What we want from an HIV patient: when was your last blood test? What is your CDT4 count? And that type of stuff, so we know that their immune system can withstand the bacteremia that we will be causing by cleaning their teeth. So sometimes we ask to see lab reports. We don't need to necessarily know how to read them, because they've got the, this is your standard, you know, they've got the range in parentheses, and this is above or below, and the dentist can help interpret that. But we use every opportunity to educate our patients, and sometimes our patients knows way more about what condition they have than we do, so we can also have them educate us. But the whole thing is that the mouth and the body are connected. So yes, we need to know what's going on with the whole body. Okay, and that is our first chapter. Are there any questions?
So I have a question. So you said just know the overall for everything, right? Not like specific stuff or like medications and stuff for the exam.